Let's go. 1 minute, sir. I am switching to the live.
Welcome, Srini.
Hi, Srini.
Hi, sir. I was in the temple. That's out.
Sir, the meeting is live now. You can start the meeting.
Happy Pongal and Makara
Good evening to all of you and a very happy new year. I am Dr. Sudha, Additional Professor at Government Medical College, Thrissur, and I'm privileged to be coordinating the online journal club, which is a presidential initiative of the Kerala Society of Ophthalmic Surgeons. We'll be holding this monthly journal club every second Friday. With me today are the President of KSOS, Dr. Chakravarti, the General Secretary of KSOS, Dr. Gopal Pillai, the Scientific Chairman, Dr. Srini Edakalam, and our guest speakers and clinical discussion professors. So here we have Professor Mahadevan sir, who's teaching and who is professor and head of department at Sri Gokulam Medical College, Trivandrum, and is long associated with the prestigious Regional Institute of Ophthalmology in Trivandrum. He is a teacher to most of us here and a vitreoretinal surgeon, initiated many of us into VR surgery. A very passionate teacher, he is still conducting multiple journal sessions and other programs through the Alumni Association of RIO Trivandrum. Dr. Leila Mohan is Academic Director of Comtrust Eye Hospital and is head of the Department of Statistical and Pediatric Ophthalmology there. She is also a passionate teacher and is responsible for bringing the fellowships initiatives into Comtrust Eye Hospital. Dr. Geethakumari will be presenting the journal, and she is an assistant professor at GMC Thrissur. So now with this introduction, I would like to invite our president, Dr. Chakravarti, to inaugurate this program.
A very good evening, friends. We are about to witness a historical event in the academic firmament of KSOS. Last 2 years, we had very busy academic schedules. 2 years back, we had about 15 or 16 webinars. Last year, 20 plus. This year, in addition to having all these webinars, we are also going to have, as Dr. Sudha just mentioned, the online journal club, which we feel is going to be very, very effective and useful to the budding ophthalmologist, as well as all ophthalmologists who are interested in ophthalmology. And I would like to thank the KSOS Executive Committee, particularly our Secretary, Dr. Gopal Pillai, our Scientific Committee Chairman, Dr. Srini, for their full support for this venture. And with these few words, I think we will move on to Sudha, and I wish this program the very best in the times to come. Thank you.
Thank you, sir. Dr. Gopal, you speak a few words.
Thank you very much. It's a really amazing thought process that Dr. Group had, which brought in this journal club. And I would like to say that journal club is the zenith of whatever an intellectual would be looking at in ophthalmology, or for that matter, any subject for that matter. So the lowest part is the instructional courses, where you will basically learn a lot of basic stuff, and then you go to analyzing the cases, and then finally the journals. So the very best, all the very best to you, Dr. Sudha. And let us hope that this will kindle a lot of enthusiasm among our younger brethren who will be keen to follow up on these journal clubs. Over to you, Sudha Madam. Thank
you. Dr. Srini, our Chairman Scientific Committee. Yes.
Yeah. It's a great initiative by our President, Dr. Arup. See, he's, we are lucky to have him as a president, somebody who has such a great stature in world ophthalmology. So he has been bringing in so much of energy he has. He wants to take KSOS. KSOS has got a level because in India, among the state societies, KSOS has got a particular high standard, and he is, I'm sure by the end of his term, this is going to be really sky high As Gopal said, see, for academics, it is a journal, and the journal club is going to help us take our academic activities to a great height. And you, Dr. Sudha, you have led the journal for the past 2 years, amazingly. And I'm sure this journal club is in very good hands. All the best, Dr. Sudha.
Thank you. Thank
Before
you so
Sudha
much.
proceeds, when I set out a clarion call for this particular program, and Sudha was one of the first few I approached, she rose to the occasion and she was so interested and enthusiastic in conducting these programs. Thank you so much, Dr. Sudha.
Thank you, all of you, and I hope I live up to this expectation. And thank you very much for giving me this opportunity. So we'll start with the journal club. Today's journal club is on myopia progression. So today we are actually changing from just treatment of myopia to treatment of the progression in children. So to catch them early, as well as to prevent the severe side effects of myopia, of high myopia. So over to you, Dr. Geetha, for presenting this journal. So
Madam, you're muted. Can you please unmute yourself? Dr. Geetha, you're muted. Can you unmute yourself?
Good evening, everyone. At the outset, I would like to thank Arup sir and Sudha madam for giving me this opportunity to present a journal in this journal club. And it's a wonderful academic program. Hope it will be very useful for PGs and young researchers for analyzing and interpreting the data. We know childhood myopia is an important emerging public health problem all over the world. The prevalence mainly, is it audible? Is it viewable, sir?
You have to make it full screen.
Yes.
We know childhood myopia is an emerging public health problem all over the world with an increased prevalence in Southeast Asian countries like Singapore, Taiwan, or Hong Kong, where it affects 60 to 70% of young adults. Whereas in India, the population-based studies showing a prevalence of around 7.5% among school-going children. So a rapid increase in the prevalence provides strong evidence that current environmental factors have important influence on the development and progression of myopia that cannot be explained by genetic influence. So a current understanding of environmental modifications can prevent the development and progression of myopia. A number of recent studies have shown a strong negative correlation between the time spent outdoors and the amount of myopia. So since then, researchers are developing some of the methods to prevent control of myopia, like starting from installing the light exposure for like glass and ceilings in school, to introducing devices for exposing bright light to retina. So in this study from China, they are proposing a device for giving exposure of bright light to retina directly in shorter duration, based on the fact that it's a proven effective method of controlling the amblyopia in Chinese population. So this is a study from the article of from the Journal of Ophthalmology published in 2021 by Jiang Yu et al. And the aim of the study was to assess the efficacy and safety of repeated low-level red light therapy in myopia control in children. So before going to the study proper, we can briefly discuss about some of the important studies in the field of myopia. The most important study is ATOM study. It's a randomized control trial from Singapore. The results of ATOM 1 and ATOM 2 are already out, but ATOM 3 is an ongoing trial. In ATOM 1, they compared the effectiveness of 1% atropine eye drops along with placebo and concluded 1% atropine eye drop is a pharmacologically good agent for controlling the myopia progression, but there was a rebound increase in the myopia following stopping of the drug along with some visual side effects. So in ATOM 2, they studied the safety and efficacy of lower concentrations of atropine and found 0.01% of atropine eye drop with lowest rebound effect and with minimal side effects was most effective concentration to reduce the progression of myopia. In ATOM 3, but the ATOM 1 and 2 studies were conducted in 6 to 12 years, but in ATOM 3, they are conducting studies in younger age, like 5 to 9 years, in young children at risk. At risk means either one of the parent having myopia, started treatment just before it starts or at the very early onset of myopia. Another important study is LAMP study, that is low concentration atropine for myopia progression. Here, the efficacy and safety of low-dose atropine were compared with placebo, and they found 0.05% was most effective in controlling myopic progression than 0.01% atropine eye drop. Next is COMET study, in which progressive addition lenses were compared with single vision lenses on the myopic progression. In COMET 1, at 3 years, there was slightly less reduction in progression with progressive addition lenses, but the difference was not sufficient to warrant a change in clinical practice. In COMET 2, at 5 years, they found there was similar progression, even though there was similar progression between two groups. Children with poor accommodation and near esophoria showed significant treatment effect with progressive addition lenses. So coming to the methodology of this study, it is a multi-center randomized single-blind clinical trial of 1 year duration. It was conducted at 5 study centers from 4 tertiary hospitals in China. They enrolled 264 eligible children from July to August 2019, with follow-up completed in August 2020. The eligibility criteria were similar to the previous studies in order to get a comparable outcome across the studies. They included children aged 8 to 13 years with myopia of cycloplegic spherical equivalent refraction of -1 to -5 diopters with astigmatism equal to or less than 2.5 diopters and anisometropy of equal to or less than 1.5 diopters and best corrected visual acuity of more than or equal to 0.0 logmar in either eye. Some of the children with any ocular abnormalities or history of any previous myopia treatment were excluded from the study. The eligible children were then randomly allocated to either intervention arm or control arm based on the centralized web-based randomization service system. The intervention arm included children, they have given single vision spectacle along with red light therapy, whereas control arm included only children wearing single vision spectacle. It is a single blinded trial where outcome assessors were masked from the study. All children were asked to wear single vision spectacle throughout the study, whereas children in intervention group were given additionally a desktop light therapy device delivering low-level red light of wavelength 650 nanometers at an illuminance of 1600 lux and a power of 0.29 milliwatt through a 4 millimeter pupil. And this level was considered very safe for direct ocular exposure. Then children in RLRL group completed treatment under the supervision of parents. They have given 3 minutes per session, 2 sessions per day with a minimum interval of 4 hours between 2 sessions, like that 5 days per week, repeated daily until the last follow-up visit at 12 months. And the compliance was monitored using an automated diary function to record the date and time of treatment session and also the treatment parameters. Coming to the main outcome measures, the outcome of interest were mainly the efficacy of myopia control and the safety of light treatment. And these measures were taken at baseline and compared to 1 month, 3 month, 6 month, and 12-month follow-up visit. The primary outcome measure was change in axial length, which was measured before cycloplegia using an IOL master. The secondary outcome measures were changes in cycloplegic spherical equivalent refraction and other biometric parameters like anterior chamber depth, corneal curvatures, white to white corneal diameter, and visual acuity using logmar chart. The choroidal thickness was an optional outcome conducted in centers where SD-OCT was available. Coming to the results, a total of 264 children were selected for this study. Among them, 116 children were assigned to the RLRL group, whereas 145 children assigned to the SVS group by simple random sampling. So this is the trial profile. Here, the 264 children were selected based on the eligibility criteria. Then they were allocated into two groups, that is RLRL group and SVS group. Then they were followed up at 1 month, 3 months, 6 months, and 12 months. And finally, children having at least one follow-up were analyzed in the final data. So like that, 117 children in the RLRL group and 129 children in the SVS group were taken for final analysis. Regarding the baseline characteristics, the median age and genders were similar. The age group 8 to 13 years were grouped into two, that is 8 to 10 groups and 11 to 13 groups. Uncorrected visual acuity, axial length, and spherical equivalent refraction were well balanced in both the groups. The primary outcome measured was the mean axial elongation. Here you can see the mean axial elongation was at the 12-month follow-up. It was 1.13 millimeters in RLRL group, whereas it was 0.38 millimeters in the SVS group. And one important point we have to look here is, here at 1 month follow, at the end of the 1 month, in the RLRL group, they showed a significant reduction, that is an axial shortening of more than 0.05 millimeters in the RLRL group, whereas in SVS group, the axial length increased of 0.02 millimeters. Regarding the secondary outcome, the adjusted mean spherical equivalent refraction progression over 12 months was minus 0.2 diopters in the RLRL group, whereas it was minus 0.79 diopters in the SVS group. The other ocular biometric parameters were almost similar in both groups, and there was no statistical difference, whereas the uncorrected visual acuity improved by at least 2 lines significantly in the RLRL group compared to the SVS group, whereas the best corrected visual acuity was same in both groups and it was not statistically significant. The association between compliance and myopia progression was also significant, means improving the compliance improved the effect of means decrease the effect of myopic progression. And even though 6 children were excluded from the study, they were discontinued the treatment. No severe adverse events were reported from this trial. Coming to certain limitations of the study, it's a study conducted. It is a study conducted in Chinese population, so we don't know whether it will be effective in our scenario, and it is a shorter duration study of 1 year, so we don't know what all control effects we can get with this light device treatment. And because of the COVID scenario, there was some of the children were lost to follow up at 6 months, but they were tried to maximize the follow up at 12 months. So these are the certain limitations. And the light device in these parameters, they found it is effective in this study, but we don't know whether the changing the parameters will affect the study findings. So in conclusion, this low-level light therapy is a safe and effective new alternative treatment for myopia control in Chinese children aged 8 to 13 years. And it was devoid of major side effects. So this is the final conclusion of their study. Okay, thank you for your patient listening.
Thank you, Dr. Geeta. That was a very concise and nicely presented. So let me now just present the statistical evaluation of this. So I'd like to share the statistical analysis of this article. So is there a well-defined research question? Now the title itself gives us the research question in this. What is the effect of repeated low-level red light therapy in myopia control in children? And we have been told that it is a multi-center randomized control trial. So if we analyze it, the population has been defined. That is children who have been progressing, showing myopia progression within the past 1 year. The intervention is repeated low-level red light therapy. Control group will be obviously there in a randomized control trial, and the outcome is myopia control. How they did it, the study design was a randomized control trial into 2 groups of intervention and control groups. So here the aim was to prove that the red light therapy is superior to single vision spectacles in treatment outcome. So it is a superiority trial, and it is a single blinded study in the sense that the patients or the children were not blinded. So there might be a little bias in reporting of adverse outcomes. Now, when you proceed for a study, you need to formulate a hypothesis. So in this case, there is 2 hypotheses which can be formed, the null hypothesis or the alternative hypothesis. The null hypothesis says that there is no difference in the efficacy between the red light treatment and single vision glasses, while the alternative hypothesis says that there is a difference. Now, usually we choose the null hypothesis and we counteract it to prove our case. So why this is there, as Albert Einstein said, it is easier to prove you wrong than prove right. So probably that is a reason why null hypothesis is considered as the easier mechanism out. So with that, we select the sample size. So why do we need a sample size? Because we have to know that whether this observed effect which we are getting is a true effect and can it be applied to the general population. And therefore, we need to have an appropriate number of participants. And this is calculated on the primary outcome or the change in the axial length. So the assumptions which have been made for this, you need 4 parameters. The alpha parameter, the beta power, the standard deviation, and the delta. So alpha they have taken as 0.05, power they have taken as 80%. The pooled standard deviation is about 0.40 millimeters, and the minimum relevant clinical difference is 50% of reduction of myopia progression. Now, what are these parameters? The power is a probability that this hypothesis testing which we are doing will detect a deviation from the null hypothesis. Only then it will be significant. What is the significant level? Alpha. See, whenever we are comparing 2 groups, you will always get some difference in the ultimate value. But this difference could be simply by chance. So to know whether this is a random answer, or is it actually because it is significant, there is actual true difference, then we need to set a level of significance. So we set 2 levels, and in between, if this value lies, then we assume that there is no significant difference. But if it lies outside this, we would like to say that the null hypothesis will be most probably rejected. We also need to, it's not just statistical significance, we also need to know whether this significance is also clinically relevant for us. So for this, they have assumed that the red light will be considered superior to single vision glasses if it reduces the annual axial elongation by 0.15 millimeter. That is about 50% reduction in effect. And now how they got this clinically relevant difference, this is what we have to do with our own experience or with previous studies. Probable study has not been published in this, but most likely it is something to do with the older studies like the COMET studies, where they have said that progressive myopes who are not under myopia control treatment tend to show at least 0.3 millimeters per year growth up to the age of 10 to 11 and slower growth after that. So when we analyze 2 groups, there could be certain biases. One of the most common bias is when we miss data, and that is because of non-adherence to the protocols. And this will change the treatment effect towards the null hypothesis. So should we lead to exclusion of data, which are those data which are not following protocol? But that would lead to unbalancing of the groups. So we must have a plan for handling the missing data in advance. So when this was done in this particular study, they have estimated a 15% loss, and they have actually adjusted the sample size of 224 participants to 264 participants. But along with this, they have done another method, which is the standard approach to RCT analysis. It is called the intent to treat method. Here, the patients are followed up as they are initially randomized. So whatever the randomization, whether they discontinue treatment or whether they switch therapy, they are analyzed in the same group. So this is to give you an unbiased estimate of the effect of treatment assignment, because if suppose somebody has complications, they may be switching treatment or they may not be following up because of the complications. So this bias has to come out, or therefore to get that unbiased estimate, we need to follow them up in the same group. But if we do that, does it affect? So do the results or conclusions change if we change our approach? So to do that, they have assessed their sensitivity analysis to determine the robustness. So they have changed the analysis also by a per protocol analysis. That means they have actually excluded those patients who shifted or who did not turn up as per the protocol. But when they repeated the analysis, they saw that the results were almost similar. So therefore, this time the findings are quite credible. The statistical model which they have used is the longitudinal mixed model to determine treatment efficacy. What do you mean by this? Longitudinal research means looking over an extended period of time. The data is correlated because as the patients are being followed up, their measurements are being repeatedly taken up various times. So their data, the present data will predict the future data. So there is correlation of the data. And also there are certain fixed effects and random effects. Fixed effects are your groups and visits, and the random effects are for the subjects. Okay. So this is what they have, it's a multiple input from various centers, and they've analyzed various groups as per age, gender, group, visit time, etc. And results Dr. Geetha has already shown. The mean difference they have found as 0.26 millimeters, which is definitely more than the 0.15 millimeter you have taken as an assumption in calculating the sample size. And it reduced the myopia by 69%, that is more than the 50% reduction. The result statistics also, they have mentioned certain things. They mentioned a point estimate, which is 0.26 millimeters, a confidence interval which they have set to this point estimates. Now, what is this? What are these factors? I'll be coming to it. What is the p-value? Now, the p-value they have found in this is less than 0.001. Now, p-value is the probability of obtaining the present result. The present result is 0.26 millimeters. Whether this result is predictive that the null hypothesis is correct. This chance is very unlikely. It is less than 1 in 1,000 chance that the null hypothesis is correct with the present test result. So we have already set a limit of 0.05 before the alpha limit. So if the p-value is less than that, the result is significant. So this test is significant and the null hypothesis should be rejected and the alternative hypothesis, that is, there is a true difference, has to be accepted. What is confidence interval? Now this sample, this is a 0.26 millimeter is a result or a point estimate of a sample. We don't know the actual value in the population because the sample may not be, or it's just a part of the population. So can we apply this to the general population? Yes, because if this is given as a range, so a confidence interval is calculated, which gives you a range from 0.20 to 0.31, which means that if you repeat multiple samples from the same population, you may get various values which lie between this range. So it is calculated for the point estimate which we have got. And how do we calculate it? We calculate it based on some confidence that this point estimate probably represents the true value in the present population, somewhere near the true value. And the confidence level of 95% has been selected by them, which means that if we test the population 100 times and we take samples from them each time, 95 of these samples will have point estimates like the confidence. So overall, the study is quite good. We would like to discuss further the clinical implications. Thank you very much. So let me move on to the present.
Yeah.
So Dr. Mahadevan, sir, would you like to comment upon this?
Yeah. Actually, as you said, from the statistical point of view, this is a very model study. They have closed all the loopholes. A beautifully designed study. But when I say it's a well-presented study, need not be a well-executed study because you're talking about the bias, which overall appears to be done well without a bias. But one slight possibility is that when you assign a few set of patients to SVS group and to the other for the RL group, there could be a bias in the execution, because which is not very evident from this paper. But one possibility is that they could have assigned a whole group of patients who are likely to progress faster to the SVS group, and created a positive result for this in the
So coming to that,
RL
sir,
study. But that is, but the confidence interval is very good throughout. So probably it is not there, I don't know, but the baseline parameters have been well matched. But this one possibility is there.
okay, coming to that,
But
sir.
overall,
So
it's
we'll just,
okay, fine.
yes, coming to that, we'll just come to the risk factors which can be
Yeah.
seen in myopia progression. Leila, madam, could you tell us what is our problem? Are we facing a myopia epidemic? And what are the risk factors we are seeing in our population in Kerala? Madam, you're muted.
Thank you, Dr. Sudha, for this wonderful getting me into this wonderful discussion on in the journal club. And of course, I have some points for and against this our strategies for myopia, preventing progression of myopia, because as I go through, of course, during this COVID times, we have been seeing some more of cases having progression, but I don't exactly know whether it is due to the patients not being followed up every year, because they come after 1 or 2 years. So sometimes there is a jump in progression, but not necessarily. And our statistics just before the COVID times does not show a very big prevalence of myopia. We have had the studies done by the DNV students. So from few schools of about 4,000, I think it was about between 3,000 to 4,000 students. So compared to Rohit Saxena's statistics in rural in the urban Delhi, our statistics does not show that much of a prevalence. There is, but we have to follow up because of this online classes and the stress upon accommodation and all these things. I think we have to watch very closely and do a proper study until we say that it is not so common. I used to always say the flat system of being indoors all the time in the flat in front of the TV or the smartphone or the digital media may be a factor in the urban cities like Bombay, Mumbai and Delhi, where the statistics show a higher prevalence than in Kerala. But in the medical students, there was a recent study from LF which showed a higher incidence of myopia among the medical students. But in school students of the same age group, we didn't have such a high prevalence in Kerala. But
Mahadevan sir, what do you think? Yes,
Yes.
Mahadevan sir has been following up
Yes.
myopia for quite some time in KSOS. Yes.
He has to-
But I was wondering what was the purpose of this study. Now it's very evident because see, we have 3 methods we have been following now. That is a single vision glass with slight hyperopic shape. Then we have been insisting on sun exposure, and then this atom study. Now, what these people have, I should really appreciate the innovative mind of the authors in applying this RRL to myopia also after their experience from treating amblyopia. They have simulated the sun exposure.
So your voice is
Cumbersome sun exposure. So that is the effect they are showing. The choroidal thickness is a very, it's an optional thing, but if you could demonstrate that, it's a great thing. Because it actually stimulates. Now, it is all not because of the vitamin D3, lack of sun exposure, is not that. It has been found that these light exposure, light impinging on the retina releases dopamine, And dopamine is like, and it has got an androgenic effect. It actually regenerates tissues, and it sends signals to the hypothalamus telling that the eyeball has matured enough, so there's no need for any more of expansion in length. That's exactly the message it sends, because otherwise the natural tendency is for the eyeball to expand from birth till about 21 years of age. The maximum expansion is by about 7-8 years, by which time children achieve 6/6. So basically they have tried to bring in the sun exposure into the room, and so that you can avoid that spending time outside and all those things. But I think although the effect is good, I think we should supplement this lower level red light stimulation. You can still supplement it with atropine and single vision glasses with hyperopic. That should be continued. If we find that red light is effective and can substitute sun exposure, we can very well follow it, but it should be combined with the other two.
You are advising a mixed, that we follow all of them together.
Even otherwise, we always tell 2-3 methods of control. We give glasses, everybody gives glasses, and 0.01% atropine, and also sun exposure if possible.
And what do you think is the 8 to 13 years has been included in this study? What do you think is the relevance? We actually think of amblyopia up to the age of 8 years. I know the concept has changed, but why do you think 8 to 13 has been included in this study? Leila, madam?
Yes, I used to believe that there is a growth spurt during which time myopia progression is also correspondingly increases during the velocity or the speed of progression has been proven to be, the lab study, they have extended the study and seen that during the Singaporean cohort study among the multiple ethnic groups have been shown that the growth spurt corresponds with the progression of myopia just before pubertal period. That is the highest, the maximum peak time where when the children attain height, and also the myopia progression increases. Actually, ATOM study is between 6 to 12 years, and this study is between 8 to 13 years. And they have divided into early 8 to 10, and 2 groups are there, which is good, because I have always felt 6 to 12 years taken as a whole does not show the progression among the adolescent period. So, so in that way, I think this may be the peak time is included in this age group, 8 to 12, 13 years.
When a patient comes to you, what is the basic examination you do for such a patient? You know whether this is progression.
Yes, when a patient, usually, even though we call school myopia that starts at 6 years, they don't come at that early age often. They come a little later, and nowadays I think probably because they are not at the blackboard, they don't even recognize that they have a blurred vision, because their the visualization is quite near. So they don't present with the blurring of vision. But definitely, once we recognize there is a myopia, even if it is very small, 0.5, we have to discuss. Nowadays, it's not just giving glasses. We have to discuss with them about the family history. We have to know whether there is a higher risk for this child to progress. And basic examination, including an accommodation lag and the phoria, muscle balance, also has to be taken into consideration when there is a progression. Actually, even if it is 0.5 or probably they may come later, maybe 1 diopter or even more. And then you bring the child again after 6 months and see whether he has progressed, the myopia is progressing. And if it is increased, definitely you have to take all the parameters with an IOL mask. The biometry has to be done to see the axial length and see whether, and also, of course, all the other parameters are also available in the biometry, and see whether if it has progressed after 6 months, then you have to discuss with the possibility of taking some of these strategies. But we have to discuss with them that once they have myopia, they have to follow the visual hygiene, the lighting standards of their studies. They should have outdoor activities definitely, and the WHO guidelines for screen time has to be followed. The children, they should not have below 2 years, they should absolutely not be on screen. The smartphone use is the commonest problem. Computer and TV, all the digital media which are more than 1 foot, they don't have so much of an implication on the progression of myopia. But all these things have to be discussed now. That is the major. Nowadays, it is not just giving glasses in myopia. We have to discuss with them before starting. And we don't start in every patient. We have to tell them that they have to continue. Quite often, what happens is they start treatment, they take for 3-4 months and then stop. So we have to discuss with them. They have to continue this at least for 2 years if they are going to start. Otherwise, there is no point.
Yes, madam. We just discussed that. Mahadevan sir, you have a lot of experience with starting Atropine. So at what age and how many years now since you started and followed up these children?
I have started Atropine at the age as early as 5 years. But now I feel, I don't know about the safety features. No, they said at children at risk, no, you start treatment early. That is the ATOM 3 study. So ROP, if you have treated ROP, I think they are at great risk. So I'm now thinking of starting treatment 0.01 at the age of 3 years, because they are definitely going to develop myopia. Those of you whom you have treated, there are ROPs you have followed up, screened, and finally they ended up with a full mature retina. You don't have to treat. So those patients you can always watch, follow up. But those treated, I'm sure most of them are going to develop myopia. So in those cases, children, I may start by 3 years or 4 years. But presently, I started them on 5 years, still waiting, because there is some amount of progression still, because once they are started on Atropine, they think, oh, that's a final drug. So they don't follow the other rules, like moving away from mobile screens or TV. They don't expose themselves to sunlight because already a drug is there. So that misconception should not be there. They should not be carried away by the Atropine treatment. I tell them every time they come, they say, it is still progress, sir. You have started Atropine. This is not enough. You need to have 3 things: the correct visual acuity with the glasses, so that a formed image will occur on the retina and they will start seeing better. And also sun exposure is a must. Apart from this, Atropine actually dilates the pupil a little, allows more light to enter the retina and allow better stimulation. So I tell them specifically that Atropine alone is not enough. So, but I'm still following up. Progression is much less. I will always say, if they come at 5 years with 2 diopters, is going to increase to about 7, 8 by the time the child reaches 21. We want to bring it down to -4 so that they become amenable to laser treatment, because beyond that, laser treatment is difficult. So at least LASIK, the cheapest way to treat. So we want to make them eligible for that, so that they'll get jobs.
That's very practical finding. Yes.
There is a question, Dr. Sudha, just one second. A question has come up in the live chat. I think, how did they decide upon the red light parameters before they embarked on the study? And from my point of view, supposing if somebody wants to start using red light in our patients based upon the results given in the study, how do we access such kind of light source?
I think this was based on amblyopia studies, and Dr. Leila Mohan will give us a better picture for that. Yes.
In fact,
how did they hit upon 650 nanometers?
It's not a standard treatment for even amblyopia, but of course the Singapore body NMP Chinese drug control body has approved RL red light therapy for amblyopia. Of course, it has been used widely for so many conditions, even for ARMD and so many other conditions also. Other than ophthalmic also, they have been using right and left red lights, thinking it has an antioxidant, or it reduces oxidative stress also. So there are studies which show there is a good effect even among adults, but it is not widely accepted. There are a lot of controversies in RL red light therapy for amblyopia also. And the protocol as to what is the ideal time of exposure to red light, all these things are not standardized yet. I think a lot more studies have to come up among with this. Now that it is seen to be safe, I think it is worth trying. I have seen a lot of studies saying morning light, exposure to morning light for few minutes every morning increases the choroidal thickness and shortens the axial length. All these studies are there, which is also near infrared light. It's also roughly 650 nano. So we are yet to standardize the protocol and how we go about it. I think we need more studies to prove that.
But it has offered a lot of hope in the fact that actually axial length has been reduced. In this study, they've shown reduction, which is the first time that anybody has shown us that all other therapies don't reduce, they arrest progression. Here actually
surprising. It is actually
this is very surprising. What do you think, Mahadevan sir? What do you think was the cause of this?
Yes. I know that's what I said. No, you should actually appreciate the innovative mind of these authors in applying this to this myopia also. They learn from amblyopia therapy that this RRL is working. And then they also used, as Leila madam said, in old people, it has worked, in dry AMD and all. The red light has stimulated the macular choroid and the RP. There's a rearrangement taking place. They are showing better choroidal thickness, although the visual acuity may not be very significantly improved. But anyway, patients feel, they have got some stimulation, some like a miracle. They are seeing something better like that. So they extrapolated those findings to now myopia therapy. But what next? 2 times only they are treating. Now I think they will come up with more frequent therapies per day, not like 2 times a day, and then from up to 8-10 nanometers, it is red light. Red diode is there. It's 8-10 nanometers. So that may burn the retina. You all know it may burn. So you cannot go up to 8-10. So maybe 650 you can increase to 700. But 720 is the dye laser, which causes again burns in the retina. So that is why they have limited the wavelength to 650. Yellow dye laser is 720, something like that. It burns. So it's 650 or even less. We can try to have less side effects and burning effects.
That answers the question well. So let us just conclude this session. Now, with what are the other alternative methods you've tried, and what do you think is the future of treatment of myopia? Madam.
Yes. Actually, once we know that they are myopic and progressing, I think we should know the phoria part of it to see whether we should give the full correction. Actually, peripheral defocus has a very big role, and if you correct it fully, especially when there is an accommodation lag and near esophoria, which may be associated with it, we should not give a full correction of myopia or the newer DIMS the focus lenses have not become very much available in India. It is soon to come. So peripheral defocus, we have to think about among these particular section who have an accommodation lag. So in those cases, we can think about optical correction because they may respond better with the progressive additional correction also. Not very high, but you may just undercorrect or give a progressive additional correction. So that may also, in addition to low dose atropine, you can add that also. And of course, in every child, we have to encourage outdoor activities, as Dr. Mahadevan in Kerala has been the first one to highlight the importance of myopia and the associated strategies, how to go about it. And I think multiple strategies should be considered in the same patient if there is a progression, which is even in ATOM study, we have seen that 20% of them are non-responders. Sometimes they, so we have to think about either increasing the dose, or in the older child, it may not be possible. So optical correction, and in addition to the increasing outdoor activities. These are the simplest ways by which we can manage these children. But of course, there are definitely they have to think about it more, because 80 to 90% of the 17-year-olds are myopic and going for high myopia too, a big proportion of them. So that's why they are looking at all these possibilities. But red light,
yes. So this red light therapy has been found to be useful, but at the same time, our teachers are telling us that we must have multiple solutions to this problem. Dr. Geetha actually has a personal question. She wants to ask Dr. Mahadevan sir her personal experience in this. Yes.
Sir, can we advise these atropine eye drops to more than 13? That's recently I have seen a child in 15 years presenting with myopia. There is no family history. So they are telling it is mainly due to the excessive mobile usage. So can we advise atropine treatment in this age group? 15 years.
Yeah, beyond 15, I have not tried, but doesn't do any harm. No, you can try.
You can try for 2 years.
2 years. And try to reduce the axial length increase.
Thank you very much, sir. We've reached, I think we've had a very good discussion. Arup sir, Gopal and Srini, any comments on this, and we'll conclude. Okay.
I think, but we had a wonderful session. Dr. Geethakumari started off with a very lucid presentation. All the salient points of that article were covered. And then finally, we had a magnificent statistical analysis done by Dr. Sudha, and then a very, very useful and practical discussion by Dr. Leila, Mohan, and Dr. Mahadevan. Thank you so much, Sudha. Keep it up.
Thank you. Dr. Gopal, would you like to say something?
Yeah, very lucid and short and sweet scientific facts, well presented, well discussed. Statistics was also brought in at the right point of time, the right amount. Thank you for the translation, clinical translation of lab into the ward. Thank you.
Dr. Srini.
Excellent statistical discussion, Dr. Sudha, and overall a wonderful program. Excellent discussions by Leila Madam and Mahadevan sir. It's a wonderful start.
Thank you for this great opportunity. The next
Don't forget to thank Ankit. The man.
Oh, yes, definitely.
Yeah, yes.
Ankit has been the force behind all this for our actually making all these arrangements. Thank you, Ankit. And the next presentation will be in February, on 11th of February, basically on a topic on cornea. So hope to see you there. Thank you very much.
Good luck to all. Good luck to all. Happy New Year and good luck to all.
Can we go offline? Are you offline or still?
Ankit, you can please stop.
Ankit?
Thank you. It was nice.